And so now I'll go into the therapeutic approaches. So most people don't know, but speech-language pathologists not only do speech and language therapy, but they also do something called cognitive rehab therapy. Speech and language therapy, it's pretty obvious. Speech-language pathologists focus on speech and or language. And cognitive rehab therapy, they mostly focus on memory and executive functioning. Executive functioning being planning a task and executing that task. And they can also do both of these types of therapy together with the patient and the caregiver. And I'll be going over both types of therapy. So for dementia care specifically, the therapy is very different than the therapy that a speech-language pathologist would do for someone who had an aphasia from a stroke. So it's really important, I'll get into this, but it's really important that you're working with a clinician who has experience working with these types of diagnoses. One of the important things to make sure that you're doing is going to the therapy sessions with your loved one. So the therapy is as much for the patient as it is for you. So you're adapting to a new way of communicating with your loved one, and your loved one is also adapting to a new way of communicating. And because the disease is progressive, it's really important that you go and you learn the strategies just in case the patient is not able to remember the strategies that are being reviewed. Compensatory strategies are usually the focus of the treatment, unlike treatment from an aphasia from a stroke. Unfortunately, the disease is progressive, so you want to work around the impairment instead of trying to improve the impairment, because unfortunately it will decline, and so we try to think of strategies to help cope with the impairment and to work around it rather than trying to, for instance, memorize a certain amount of words, because unfortunately those words might not be remembered a week, 2 years later. So really the therapies oftentimes focus on compensatory strategies rather than rehabilitative ones. Personalized treatment is really important. So these diagnoses look very different from each other. So if a clinician is working with a patient with behavioral variant FTD who's in his 40s, who's still working and has 4 young children, versus working with someone in their 80s who has Alzheimer's disease and is in assisted living with no children, the strategies will be very different because they're not going to be functional if they're the same, right? They're not going to work for those 2 different types of people. So it's really important that the treatment is personalized. Support groups are really important. This is a really hard diagnosis to have. It's hard for the caregiver to have. It's hard for the patient. So support groups, especially for caregivers, are really important to be part of. That's also community resources. Our clinic is really good and specialized in these diagnoses. And once we make a diagnosis, if you live far away, it's really important that you have a team of specialists or health professionals that we've at least talked to and given treatment recommendations to that you have more access to. And the goal is functional communication. So functional communication is basically getting the message across, but maybe not in the perfect way or the ideal way, but using the strengths of the patient and the caregiver to get the message across. And also participation in daily activities as independently as they can, because the caregiver can't be everywhere all the time. So we need to think of strategies to help your loved one participate in daily activities as best as they can. So those are the 2 goals of the different types of therapy, and so we just need to make sure that you're working with someone where they know that these things are important for dementia care. For treatment recommendations, I usually recommend 3 to 10 sessions and then returning when appropriate. So basically that means you work with the clinician, you develop strategies that you try at home, see if they work, and then because it's a progressive disease, the decline in the disease may lead to new issues that come up, and so if you're feeling like the strategies are no longer working or no longer working as well, you come back for more therapy and develop new strategies that may be more helpful. They're usually 45 minutes once a week. You don't need to go for, for an entire year. You just develop the strategies, you practice them at home, make sure that they work, and then come back when it's appropriate. Like I said, it's important that the patient and the caregiver attend all sessions, practice the strategies at home so you know what works and what doesn't work, and then work with someone who has experience with dementia diagnoses. If you don't know of anyone, then I'm more than happy to help find the right speech-language pathologist in the area. We have a list going of people that we've referred individuals to, and if no one's in the area that you're living at, then what I do is I contact the speech-language pathologist at a rehab, hospital, or clinic that you live near, and then I provide treatment recommendations to that person and educate them a little bit about the diagnosis that your loved one has. So like I said, most of the strategies, I recommend compensatory strategies. So talking around words instead of trying to think of that exact word that they want to use is really important. I'll go over that a little bit more. But so usually when a person is trying to find that exact word they want to, they oftentimes do not find that word. And what happens is their anxiety goes up, their frustration goes up, and then usually the communication exchange just ends because they become too frustrated by it. So really what you want to get in the habit of doing is practicing talking around words instead of getting frustrated and anxious that you're not finding that word that he or she wants to get at. And I'll talk a little bit about the strategies that we use to help with that in the next slide. Drawing, gestures, and writing are really helpful sometimes. People usually don't realize how much facial expressions and gestures help with communication. Speech isn't the only way of getting language out. So especially people who have difficulty with articulating their words, drawing and writing can be really helpful. Structured yes/no questions can be helpful, especially if your loved one has any apathy and doesn't want to initiate conversation or doesn't want to respond. They're more likely to respond to a question if the answer is just yes or no instead of an open-ended question. Assistive technology is important for people with who have difficulty with articulating words. And then our impairment-based strategies are also helpful. I usually recommend compensatory strategies because I think it's more functional because the disease is progressive, but I'll go over a little bit of what semantic feature analysis is, just in case people are interested. And then pre-written scripts, there's been research for the non-fluent agrammatic patients or people with progressive supranuclear palsy or corticobasal syndrome, the people who have difficulty articulating the sounds of words. So what the clinician would do for the pre-written scripts is they would think of situations, communication exchanges that they often experience. So for instance, if the patient is a hairdresser and she has a similar conversation on a day-to-day basis with a customer, she or he and the clinician will write a script together in simple language, and then the clinician will videotape herself articulating the words, and then the patient will practice at home and in the clinic that pre-written script over and over and over again. And then research has found that helps with articulating the sounds correctly. But again, it's a progressive disease, and so it's only a certain amount of time where that will be helpful. But it is found to be helpful for a certain amount of time in those common communication exchanges that they have. It's really just up to the caregiver and the patient of what they feel like is the best approach in either pre-written scripts or something like assistive technology to help or writing to get their messages across. And I'll go over semantic feature analysis in this slide. So semantic feature analysis is an impairment-based strategy for word retrieval difficulty. So what you do is the clinician, the patient, and the caregiver think of words that they commonly use that they have difficulty finding, maybe let's say 50 to 100 words that they have difficulty retrieving on a daily basis. You write those words down, you practice writing them, you practice saying them, you write them in sentences, you think of different semantic features of the word, maybe what's it used for, what does it look like, where is it located, and then you practice those words over and over again in the clinic and at home. And then research has found that it helps people remember those specific words for a certain amount of time. But again, because it's a progressive disease, they lose those words eventually too. But research has found that has helped remember those specific words for a certain amount of time. And then again, it's up to the patient and the caregiver if they want to use this approach, because it unfortunately uses a lot of time to remember these words, but maybe that's important to the family and the patient. A compensatory strategy for word retrieval is something we call PAL, so it stands for Purpose, Appearance, and Location. And basically we try to get the individual in the habit of talking around words instead of trying to find that exact word. So you think about the purpose, the appearance, and location. So for instance, if they're thinking of the word apple, the purpose is you eat it. Location, it grows on trees. You can buy it in a supermarket or a store. Appearance, it's red and round. So they may be able to come up with those semantic features of the word, even if they can't get at the exact word. But it takes a lot of work and practice with the clinician and the caregiver to get in the habit of talking around words instead of using the exact word that they want to use. And this is also helpful for caregivers because you can help cue the individual in talking around the words. So if they're having difficulty talking about something and they're just, like their communication is breaking down, you can say,